Assalamu alaikum. I am Dr. Rowshon Ara Khatun, Associate Professor of Gynae and Obst in Akij Medical College, Khulna. We are going to discuss about postpartum hemorrhage. First of all, we should know what is postpartum hemorrhage. According to WHO, the amount of blood loss excess is 500 ml following birth of the baby is called postpartum hemorrhage. But clinically, any amount of bleeding from or into the genital tract following birth of the baby up to the end of puerperium, which adversely affects the general condition of the patient, evidenced by rise in pulse rate and falling blood pressure, is called postpartum hemorrhage. The average blood loss following vaginal delivery is about 500 ml. In caesarean delivery, it is 1000 ml, and in caesarean hysterectomy, it is 1500 ml. Depending upon the amount of blood loss, postpartum hemorrhage is divided into minor, major, and severe. When the blood loss is less than 1 liter, then it is called minor postpartum hemorrhage. When more than 1 liter, then it is major postpartum hemorrhage, and when more than 2 liter, then it is called severe postpartum hemorrhage. Now, incidence of postpartum hemorrhage. The incidence widely varies, mainly because of lack of uniformity in the criteria used in definition. The incidence is about 4 to 6% of all deliveries. Now, types of postpartum hemorrhage. We are dividing two types of postpartum hemorrhage. Number 1, primary postpartum hemorrhage, and number 2, secondary postpartum hemorrhage. In primary postpartum hemorrhage, hemorrhage occurs within 24 hours following the birth of the baby. In the majority, hemorrhage occurs within 2 hours following delivery. There are of two types: third stage hemorrhage and true postpartum hemorrhage. When bleeding occurs before expulsion of placenta, it is called third stage hemorrhage. When it is occurred subsequent to expulsion of placenta, it is called true postpartum hemorrhage. Secondary postpartum hemorrhage. Hemorrhage occurs beyond 24 hours and within puerperium, also called delayed or late puerperial hemorrhage. Now we shall discuss about the causes of primary postpartum hemorrhage. According to RCOG, there are 4 basic pathologies are expressed as the 4 T's. Number 1, tone, that means atonicity of uterus. Number 2, tissue, that means retained beads or blood clots. Number 3, trauma, genital tract injury, and number 4, thrombin or coagulopathy. Now, atonicity or atonic uterus. Atonicity of the uterus is commonest cause of postpartum hemorrhage. It is about 80% cause. With the separation of placenta, the uterine sinuses, which are torn, cannot be compressed effectively due to imperfect contraction and retraction of the uterine muscles, and bleeding continues. The following are the conditions which often interfere with the retraction of the uterus as a whole and of the placenta site in particular. Number 1, grand multipara, overdistension of the uterus, malnutrition and anemia, antepartum hemorrhage, prolonged labor, anesthesia, initiation or augmentation of the delivery, malformation of the uterus, uterine fibroid, mismanagement third stage, placental cause, precipitate labor, and other causes. Now, grand multipara. Inadequate retraction and frequent adherent placenta contribute with it. Associated anemia may also probably play a role. Overdistension of the uterus as in multiple pregnancy, hydramnios, and big baby more than 4 kg, imperfect retraction and a large placental site are responsible for excessive bleeding. Malnutrition and anemia, hemoglobin less than 9 gram per dl. Even slight amount of blood loss may develop clinical manifestations of postpartum hemorrhage. Antepartum hemorrhage, both placenta previa and abruptio placenta causes of excessive bleeding. Prolonged labor, more than 12 hours, poor retraction, infection, and that is amnionitis, dehydration, and important factors are atonicity, anesthesia, depth of anesthesia and the anesthetic agent, that is ether halogen, may cause atonicity of the uterus. Initiation or augmentation of delivery by oxytocin. Post-delivery uterine atonicity is likely unless the oxytocin is continued for at least 1 hour following delivery. Now, malformation of the uterus. Implantation of the placenta in the uterine septum of a septate uterus or in the cornual region of bicornuate uterus may cause excessive bleeding. Uterine fibroid causes imperfect retraction mechanically. Mismanaged third stage labor. These include too rapid delivery of the baby, preventing the uterine wall to adapt to the diminishing contents. Premature attempt to deliver the placenta before its separation. Kneading and fiddling of the uterus. Pulling the cord, all these produce irregular uterine contraction leading to partial separation of the placenta and hemorrhage. Manual separation of the placenta increases blood loss during cesarean delivery. Placental cause, morbidly adherent placenta, that is placenta accreta or percreta, partially completely separated and or retained placental bead cause PPH or postpartum hemorrhage. Precipitate labor. In rapid delivery, separation of the placenta occurs following the birth of the baby. Bleeding continues before the onset of the uterine retraction. Bleeding may be due to genital tract trauma, also cause PPH. There may be some other causes like obesity, BMI more than 35, previous PPH, age more than 40 years, drugs used as in procolytic drug or magnesium sulfate or nifedipine cause postpartum hemorrhage. Now we shall tell the traumatic cause of postpartum hemorrhage. Trauma to the genital tract usually occurs following operative delivery. Even after spontaneous delivery may occur. Blood loss from the episiotomy wound is often underestimated. Similarly, blood loss in caesarean section amounting to 800 to 1000 ml is most often ignored. Trauma involved usually the cervix, vagina, perineum, that means episiotomy wound, and laceration, paraurethral region, and rarely rupture of the uterus. The bleeding is usually revealed but can be rarely concealed like vulvovaginal hematoma or broad ligament hematoma. Now, the third cause of postpartum hemorrhage is retained tissue. Beads of placenta, blood clots cause postpartum hemorrhage due to imperfect uterine retraction. Sometimes atonicity of the uterus and trauma to the genital tract combinedly cause postpartum hemorrhage. Now, fourth cause, thrombin. Blood coagulation disorders, acquired or congenital, are less common causes postpartum hemorrhage. The blood coagulopathy may be due to diminished procoagulants or increased fibrinolytic activity. The firmly retracted uterus can usually prevent bleeding. The conditions where such disorders may occur are abruptio placenta, jaundice in pregnancy, thrombocytopenic purpura, severe preeclampsia, HELLP syndrome, or in intrauterine fetal death. Specific therapy including recombinant activated factors 7 may be given. Diagnosis and clinical effects. In the majority, the vaginal bleeding is visible outside as a slow trickle. Rarely, the bleeding is totally concealed as either vulvovaginal or broad ligament hematoma. The effect of blood loss depends on pre-delivery hemoglobin level, degree of pregnancy-induced hypervolemia, speed at which blood loss occurs, alteration of pulse blood pressure and pulse pressure appears only after class 2 hemorrhage, that is 20-25% loss of blood volume. On occasion, blood loss is so rapid and brisk that death may occur within a few minutes. A state of uterus, as felt per abdomen, gives a reliable clue as regards the cause of bleeding. Traumatic hemorrhage, the uterus is found well contracted. In atonic hemorrhage, the uterus is found flabby and becomes hard on massaging. However, both the atonicity and traumatic cause may coexist. Even following massive blood loss from the injured area, a state of low general condition can make the uterus atonicity. Prognosis. Postpartum hemorrhage is one of the life-threatening emergencies. It is one of the major causes of maternal death, both in the developing and developed countries. Prevalence of malnutrition and anemia, inadequate antenatal and intranatal care, and lack of blood transfusion facilities, substandard care are some of the important contributing factors. There is also increased morbidity. These include shock, transfusion reaction, puerperal sepsis, falling lactation, pulmonary embolism, thrombosis and thrombophlebitis. Let's sequelae include Sheehan syndrome or rarely diabetes insipidus. Now we shall discuss about prevention of postpartum hemorrhage. Postpartum hemorrhage cannot always be prevented. However, the incidence and especially its magnitude can be reduced substantially by assessing the risk factors and following the guidelines as mentioned below. However, most cases of postpartum hemorrhage have no identifiable risk factors. Now we can take measures about antenatal care. In antenatal care, improvement of the health status of the woman and to keep the hemoglobin level normal more than 10 gram per dl, that the patient can withstand of some amount of bleeding or blood loss. However, most causes of postpartum hemorrhage have no identifiable risk factors. Now, antenatal. During antenatal care, improvement of the health status of the woman and to keep the hemoglobin level at normal more than 10 gram per dl, so that the patient can withstand some amount of blood loss. High-risk patients who are likely to develop postpartum hemorrhage are such as twins, hydramnios and malnutrition, grand multipara, antepartum hemorrhage, previous postpartum hemorrhage and severe anemia are to be screened and delivered in well-equipped hospital. Blood grouping should be done for all women so that no time is wasted during emergency. Placental localization must be done in all women with previous caesarean delivery by ultrasonography or MRI to detect placenta accreta or percurata. All women with previous caesarean delivery must have their placental site determined by ultrasound or MRI, determine morbid adherent placenta. Women with morbid adherent placenta are at high risk of postpartum hemorrhage. Such a case should be delivered by a senior obstetrician. Availability of blood products must be ensured beforehand. Multidisciplinary team approach should be such a case. Now, internatal care. Active management of the third stage for all women in labor should be routine, as it reduces postpartum hemorrhage by 60%. Cases with induced or augmented labor by oxytocin, the infusion should be continued for at least 1 hour after the delivery. Women delivered by cesarean section, oxytocin should be given to reduce the blood loss. Carbetocin, that is long-acting oxytocin, is very useful to prevent postpartum hemorrhage. Exploration of the uterovaginal canal for evidence of trauma following difficult labor or instrumental delivery. Observation for about 2 hours after delivery to make sure that the uterus is hard and well contracted before sending the patient to ward. Expert obstetric anesthetist is needed when the delivery is conducted under general anesthesia. Local or epidural anesthesia is preferable to general anesthesia in forceps, ventouse or bridge delivery. During cesarean section, spontaneous separation and delivery of the placenta reduces the blood loss 30%. Examination of the placenta and membranes should be a routine to detect at the earliest any missing part. All said and done, it is the intelligent anticipation, skilled supervision, prompt detection and effective institution of therapy that can prevent a normal case from undergoing disastrous consequences. Now we shall discuss about the management of third stage bleeding. The principle of third stage bleeding management are to empty the uterus of its content and to make it contract, to replace the blood loss on occasion. Patient may be in shock. In that case, patient is managed for shock first to ensure effective hemostasis in traumatic bleeding. Steps of management. Steps of management are in placental side bleeding and in traumatic bleeding. Placental side bleeding. To palpate the fundus and massages the uterus to make it hard. The massage is to be done by placing forefingers behind the uterus and thumb in front. However, if bleeding continues even after the uterus becomes hard, suggests the presence of genital tract injury. To start crystalloid solution, normal saline or Ringer's lactate with oxytocin and to arrange for blood transfusion if necessary. Oxytocin 10 units IM or methergine 0.2 mg is given intravenously. Carbetocin, a longer acting oxytocin derivative, is found effective as oxytocin infusion. To catheterize the bladder, to give antibiotics. During this procedure, if fissures of placental separation are evident, expression of the placenta is to be done either by fundal pressure or controlled contraction method. If the placenta is not separated, manual removal of placenta under general anesthesia is to be done. However, if the patient is in shock, she is resuscitated first before undertaking manual removal. If the patient is delivered under general anesthesia, quick manual removal of the placenta solves the problem. In cases where oxytocin 10 units is given IM with the delivery of the anterior shoulder, manual removal is done promptly when 2 attempts of controlled contraction fails. Now, management of traumatic bleeding. The uterovaginal canal is to be explored under general anesthesia after the placenta is expelled and hemostatic sutures are placed on the offending site. Now, there may be some difficulties in manual removal of placenta. The difficulties are hourglass contraction leading to difficulty in introducing the hand, morbid adherent placenta which may cause difficulty in getting to the plane of cleavage of placental separation. In such a case, placenta is removed gently in fragments using an ovum forceps. Complications in manual removal of placenta: hemorrhage due to incomplete removal, shock, injury to the uterus, infection, inversion in rare cases, subinvolution, thrombophlebitis, embolism. In such cases, placenta is removed in fragments using an ovum forceps or a flushing curette. Today we are finishing our discussion. The remaining portion we'll discuss next day. Thank you. Allah Hafiz.